Okay, so I do not have any financial disclosure here, and if I have to show you one slide, this is the slide which I'm going to show you. So when we have cone, we divide them into whether it's a central cone or decentered cone, or it's an advanced keratoconus. If it's a centered cone and if it's stable, we don't do cross-linking. If it's not stable, obviously we are going to do cross-linking. If it's a central cone where spherical equivalent is very high, we do cross-linking and then visual rehabilitation, phakic IOL. Low spherical equivalent, Intex can do the job and you're fine. Decentered cone, if it's stable, we don't do cross-linking. If not, do cross-linking and combine with either Intex, or if we have good corneal thickness, we can do topo guided treatment. Final, for the visual rehabilitation, we can do phakic IOLs or we can do toric IOLs. If it's an advanced cone, however, the treatments are a little different what Abhishek actually showed us. So if it's advanced cone, we do contact lens trial first. Mind you, I'm not saying that give contact lens, but do trial whatever best you have. See the contact lens fitting. If fitting is good, patient is willing, and you think the corneal thickness is decent enough to do a different cross-linking, what Gitansha showed us in thin cornea and those things, do cross-linking and then do visual rehabilitation. But if Pachy is not good, then Abhishek showed us that you can still give them contact lens, wait for corneal transplant for a long time. But the fitting is not good of contact lens or patient is not willing, we can go ahead with corneal transplant. So I'll keep my talk more case-based, and if we can see from here, a person who had undergone cross or came for cross-linking with the pentacam Pachy of 384 micron. Well, that means if we remove 50 micron, we have 334 micron stroma available for cross-linking. With normal our HPMC riboflavin, we can do cross-linking in these cases. But then if we do something like ASOCT, you realize you were actually fooled. The epithelium was not 50 micron. Epithelium here was 131 micron. Hence, the stroma available was just 206 micron. Not the best case to do cross-linking. Well, we can do contact lens trial, keep the patient ready for corneal transplant if patient is interested. However, the vision is very good, patient might want to continue. So what do we learn here? Very advanced cone, your pachymetry on Scheimpflug imaging like pentacam may not be very accurate. Use more advanced diagnostic like ASOCT. Another case underwent cross-linking and post-op 1.5 years, and you can see from here two maps, one the curvature map, post-op and pre-op, and it shows significant flattening. So is the anterior elevation map shows flattening. So it means it's successful cross-linking. But if we see now posterior elevation map and pachymetry map, it shows actually reduction. So pachymetry is reduced, posterior elevation shows increase. So this means failed cross-linking. Now how does this happen? Anterior surface successful cross-linking, but Pachy and posterior elevation shows failed cross-linking. Well, that's where the densitometry comes into picture. Always look at the raw data on your pentacam and go and see them how much exactly the densitometry is. When the densitometry values are very high, your reliability of pachymetry as well as the posterior elevation can be very poor. So what do we learn from here? That in advanced cross-linking or wherever we have the haze, your pachymetry on pentacam may not be very reliable. Remember, whatever we do, our final goal has to be visual rehabilitation. So whenever we do cross-linking, we still need to have plan in our head that what do we do to do visual rehabilitation in such patients. So if it's a central cone and lower spherical equivalent, we saw earlier that the intracorneal rings can be really wonderful thing. If I have to choose only one indication for intracorneal ring implants, I would use it for post-LASIK ectasia, and it works wonderfully well. It makes the surface as if it was nothing but the LASIK done. So if you have one treatment required, that would be post-LASIK ectasia. Another thing, when you have high spherical equivalent, you can use phakic intraocular lenses, toric, ICL, IPCL, whatever suits your hand. These cases must be selected properly. So one such case had cross-linking done and did a toric ICL and got a good visual outcome, but patient was not happy because patient had uniocular diplopia, and this was because it's a decentered cone. And I learned my lesson that phakic IOLs are best reserved for central cone and not decentered cone. One more such case had cross-linking done, came to me after long follow-up, and I said, don't worry, I'll take care of you, central cone, juicy cone. But when you do a refraction, the refraction axis from topographic axis was very different. So topographic axis 70, refractive or subjective refraction axis 20. What do you choose? And such kind of cases are not best. So what do we learn from here? Well, phakic IOL in keratoconus can be used in central cone, spherical equivalent if high works better. But topo and refraction, they are not correlating, just be careful. If the person is little senior age group and you have like cataract, as you can see from here, you can think of customized toric IOL also. So one such case had central cone and had axial length of 32.6, did a customized toric IOL, and the lens implanted was minus 12.5 spherical and 4.5 cylinder. Patient did well. So even such kind of advanced cases, your custom toric lens can help. So what did we learn from here? Customized toric lens can help you in visual rehabilitation in selected cases. The final part of my talk, I'm just going to touch up something which Shreyas told us. A case, keratoconic case with good pachymetry, more than 500 pachymetry and low refractive error. Well, what do we choose? Well, we can choose topo-guided customized treatment. What it does is central cone, it reduces the spherical power. We may not totally take care of the spherical power or decentered cone, it makes it little more regular. And if we can achieve that, that's decent enough. So this case, left eye where little more spherical power was this is topo guided treatment. So it reduced the cone, but will it disappear the cone? Not necessarily. But is that the only customization possible? Well, no. In fact, there are some other things which can be done. Not all of us can have topo-guided treatment. Some of us have wavefront-guided treatment or abrometry-guided treatment. You can also do a wavefront-guided treatment in such kind of cases. When do we do? Well, if you have reliable wavefront data, when you have low refractive error, because wavefront-guided treatment does not allow you to undercorrect significantly. And in such kind of cases, you can do. So same patient, I did right eye wavefront guided PRK and reduce the refractive error because refractive error already was less. And you can see from here preoperatively and postoperatively remarkable improvement in patient had unaided 6x6 vision. So what do we learn from here? Customized PRK, either topo guided or wavefront guided, can be done. High refractive error, low pachy, topo guided is best. Low refractive error with decent pachy, wavefront guided treatment can also be done. So to finally summarize, central cone, decentered cone, progressive or non-progressive or non-progressive, high spherical equivalent, phakic IOL, low spherical equivalent, intacs. Decentered cone, intracorneal rings, if you can have single segment also, you can put that. Final visual rehabilitation, either phakic IOL or toric IOL. Thank you very much.